go into PTH, calcitonin, vitamin D, which are the three plasma calcium. So, you know that there is a great exchange between different compartments, calcium and phosphate levels. The largest concentration is found in the bone, as you know, and some activities can lead to resorption of the bone, where calcium and phosphate are released. Some activities could also lead to the uptake of these processes during osteoblastic activity, and during osteoclastic activity, the reverse occurs. So calcium and phosphate are absorbed from the gastrointestinal tract. There is also some secretion from the ECF that goes in there, and then excretion in the feces. An important site is the kidneys, where most of these substances are either reabsorbed or secreted. So there are various sites where those exchange occur. So we have said about 99% of calcium is found in bone, and the concentration is about 2.4 millimoles per liter. That's the one you use now, isn't it? Those of us in the old school, we still use the milligram per deciliter. 50% of it is in ionized biological active form, whereas the other ones are not in active form. 40% bound to proteins, 10% in complex salts. Major source is dietary, and the absorption increases in an acid environment. What are some of the functions? Formation of bone and teeth, tissue excitability, muscle contraction, blood coagulation. Calcium is factor what? 4, and you can see its ubiquitous, it's almost in all the steps. So it plays a major role in blood coagulation. So because of this myriad of functions, there is need for fine regulation. That's why we don't use EDTA, anticoagulant, in vivo. You only use it in vitro, because if you give it in vivo, it will destabilize the calcium milieu, and you don't want that to happen. So there is need for fine regulation of both extracellular calcium as well as cytosolic calcium. So there is need for fine regulation of extracellular and cytosolic calcium. So the control of calcium is carefully maintained both extracellularly and in the cytosolic. Intracellular stored mainly in the mitochondria and then endoplasmic reticulum. You remember your calcium, your triad in muscle contraction? Remember the triad? So when extracellular calcium falls below normal, the nervous system becomes progressively more excited because of increased permeability of neuronal membrane to sodium. So something I should have said by way of introduction is that the parathyroid glands are essential for life. So, for argument's sake, if the body lacks thyroid gland or lacks thyroid hormone, you can supplement it and the person can still survive. But the reverse is the case with the parathyroid gland. Because of the ubiquitous function that calcium plays, if there is inadvertent removal or atrophy of all the parathyroid glands such that PTH is not produced, the individual dies from laryngeal asphyxia. So the parathyroid gland is essential for life. How does this happen? Calcium and sodium, they have the same valency and they share the same channels. So if PTH is removed, the parathyroid glands are removed, there is no PTH, it means that there will be no means of increasing the plasma calcium level, right? So the plasma calcium level will be low. And because the plasma calcium level is low, the rate of influx of sodium into the tissue now increases. So what will be the consequence of that?
Hyponatremia.
Hyponatremia. So what does that lead to in terms of the resting membrane potential, action potential?
It decreases.
So the resting membrane potential changes, there is an increased rate of action potential. So the action potential now increases such that the laryngeal muscles, that they are very small groups of muscles. And then when they remain in that tetanic contracted state, what happens? They come closer and block the airway.
So is that experience tetany?
Yes?
Is that experience tetany?
Yes. So the consequence is that their increased and sustained contraction will prevent air from going to the airways, and there will be death from laryngeal asphyxia. Yes?
Did you say that the resting membrane increases?
Tell me.
I know it's going to become more positive. But
Yeah, so there is increased rate of an action potential firing.
So are you saying it decreases?
You tell me from where. I'm not teaching you awareness now.
Yeah.
The positivity, what is the value of the resting membrane potential? Okay, so when it tends towards an action potential, what happens? More positive, yes. And then there's an ease of firing of action potential. But are you looking at negativity or positivity?
Like, when you're asking about different potential, is it decreased or increased?
If you go from -90 to +30, now, let's not argue about the signage, but to understand the physiology, I'm saying, action potential goes from the resting membrane potential moving down towards the firing level. And it is that rapid influx of sodium relative to the decrease in calcium that leads to the increased muscle contraction. Yes?
So, I get what you're saying. So, down there we have hypocalcemic. Is that separate?
What?
So, you're talking about low calcium and then the tetanus, right? And the allergic fixation. Where you have hypocalcemic in there, is that something?
Cytosolic.
Oh,
Cytosolic. Cytosolic. So that's why I said there is fine maintenance between what happens in the extracellular and what happens in the cytosol.
So, it's hypocalcemic lower than calcium.
Yeah, so the hyperexcitability can cause some tetanic contractions. So you have hypercalcemic tetany. So that can also occur with respect to the cytoplasmic or cytosolic calcium. So I'm just trying to explain the physiology why the parathyroid glands are essential for life. So basically sodium and calcium share the same channel. So if one is low, the rate of entry of the other increases. And we know what sodium does. Hello? That gentleman at the back, you are still with your cell phone or you are listening to my lecture? Are you listening? Okay. Alright, so That's why the parathyroid are essential for life. So the regulation of calcium and phosphate, they are tightly regulated such that when one is increasing, the other one is decreasing. And interestingly, the product of their concentration is always a constant. Because if calcium is going up, phosphate should come down. Phosphate going up, calcium should come down. And the product of their concentration is always a constant. And if it exceeds a critical value, it suggests that there is a likelihood of the formation of calcium stones. So for phosphate, about 80% of it is present in bone. That's the concentration, which varies inversely with that of calcium. And I've just said that the product of their concentration is always a constant, about 70 thereabout. And when this value exceeds, say, about 100, then there is the likelihood of the formation of renal stones. So what is, let me pick your brain quickly now. What is the average calcium level? I gave you some figures in milligram per deciliter. You remember? It's about 9 to 11, 9 to 12, thereabout. And then phosphate in an adult, say 5 or 4 milligrams per deciliter. So if you say 9 and then you multiply it by 10 or 12, that's just about what? 9 by 5, 45, so it's still low, still below 70. So if you hypothetically have values, when they exceed 70, you will know that the concentration of either calcium or phosphate is high. And then there is the likelihood of the formation of renal stones.
Sir, go over that again.
Yes.
Is it 70 or 100? Which one is it?
Eh?
You say it's either 70.
I said approximately 70. So when it goes close to 100, when it gets closer to 100, then it is high. Yes, what is your question?
Sir, I was saying that go over it again because, so you're saying that when you compare the calcium, when you multiply the calcium concentration as well as the calcium levels as well as the phosphate levels.
Yes.
Right? You're saying that if you have any value over 70 or going towards 100.
It suggests formation of renal stones, yes.
Formation of renal stones.
Kidney stones, yes.
Okay. And if it's below, it just means that
If it's normal,
it's normal. Okay.
if it's normal, it's normal. It's
Thank
just
you.
an arbitrary figure that will help you, yes. Go ahead, quickly.
So if you're saying that it's close to 100, that's indication of your stone.
Hmm?
So you're saying if it's close to 100.
Yeah, if it's above 70, going to close to 100, then it suggests there could be formation of renal stones.
Okay, the one they need. Okay.
Yeah. So it just means that the product should be within values that are below 70. All right, we looked at that. Functions of phosphate, we know. Integral part of glycolytic compounds, regulation of blood and urine pH, part of energy transfer compounds, major anion in bone and teeth. Right, so just a pictorial to show you
Not so far off.
the location of the parathyroid gland. You've done the histology of it.
Yes.
So tell me about the histology.
So you have about the histology?
Yeah, tell us
What type of cells do we find there?
Oxyphilic.
Chief cells, oxyphilic cells, another one. You could also have a thought that the water clear cells, which are found when there is hyperplasia. What are the functions of the chief cells?
To produce parathyroid.
Oxyphilic cells?
No use. They're just there.
Well, their functions are not quite clear, but they are thought to be involved in storage and in energy production. When do they appear? At puberty. That's when you see them come up. Chief cells secrete parathyroid hormone. Oxyphilic cells may be involved in storage and in energy production.
Sir, could you clarify something for me? So that when you reach puberty, the parathyroid.
No, when you reach puberty, that's when the oxyphilic cells increase at puberty. Then the water clear cells appear when there is hyperplasia of the gland.
Sir, is it usually the oxyphilic cells? That's why you have a lot of adipocytes. With the oxyphilic cells, would be the reason why you have adipose tissue.
It could be, I'm not sure, but it has to do more with
The metabolism.
storage of hormones and also energy.
Okay.
Functions. The functions of the PTH include increased calcium level by increased renal tubular absorption. This is a very enormous response, but it is a little bit slower. It also increases bone resorption, and this is a rapid and more sensitive function. So the first function is enormous, but slightly slower. The function on the bone is fairly rapid, but more sensitive. It also has some effect on calcium absorption from the gut. I have just said that parathyroid glands are essential for life because their removal can cause death due to asphyxia from laryngeal spasm, and then try to explain the physiology behind that. Yes?
Sir, when you say that bone resorption is sensitive, what do you mean? When you say sensitive,
It's more finely regulated. Finely regulated. But the tubular resorption is, well, if you want to look at it in terms of either the duration or the enormity of what is secreted, but these are the actions, okay? So just take it as the actions, and then we will look at the mechanisms as we go along. Right, now look at this. This is what we need to point out and get. When there is action of PTH on the bone, it increases osteoclastic activity, right? Following that increased osteoclastic activity, both calcium and PTH are released from bone because both of them are found in the bone. So the action of PTH on the bone will cause the release of both calcium and phosphate. But remember, we have just now said that the concentration of calcium and phosphate in the ECF is inversely related. Right? When one is high, the other one is low. So at this instance, we see that the action of PTH on the bone will cause both increased calcium and increased phosphate. But now see what happens with the kidneys now. The action of PTH on the kidneys will cause significant efflux of phosphate. It will cause increased excretion of phosphate and increased calcium reabsorption. So this net effect will bring about the correction of the concentration such that phosphate level now will ultimately decrease while calcium level will ultimately increase. Yes.
What's the point?
What's which point? Because the phosphate and the calcium are bound in your hydroxyapatite, they are together. So there is no way you can separate one from the other. So once there is osteoclastic activity, both of them are released. But the body now has a homeostatic mechanism to return the homeostasis to that inverse relationship. Yes? Speak up, please.
You said that it's gonna
Eh?
So the parathyroid hormone increase both calcium and phosphate is moved from the bone.
Yes.
And then the kidney is gonna cause excretion of the phosphate.
Increased excretion of. Go
I
ahead.
understand that you say it's an inverse relationship, right? But why does that happen?
Why?
Why does it have to be like that?
Because it has to be like that to maintain the original relationship that I explained. Because if there is an increase in the product of the concentration above, yes. You okay? What's your name again?
Oh, my name is Jana.
You are the one with the Bob Marley t-shirt?
No.
That's the Bob Marley t-shirt.
All right. Can I go on now? Now, see what happens from the gastrointestinal tract. There is reabsorption of calcium
He's not going over everything.
from the gut into the ECF and also from the
Sir, question.
Yes.
Dr. Pepper, I'm seeing vitamin D on the diagram.
Yes.
So what is
What
it?
does it
We
incorporate?
will come
How
to
does
it.
incorporate?
We'll come to it. There are three major hormones involved in calcium homeostasis. We are just focusing on PTH. We will come to calcitonin and then we will look at vitamin D, whether you will agree whether if it's a hormone or not.
I agree with whatever you say.
Hmm?
I believe whatever you say.
Sir,
I'm not a preacher.
You gotta set the test though. So
increased calcium,
I
right?
think I'm too
Where? Increase calcium where?
I think the
Increased
N
blood
is the
calcium.
array. If
Where?
the Q is not on the top.
Increased blood calcium overall, right? You said that could be indicative of renal stone.
No. Increase the product of calcium and phosphate if it's above a critical level. We have an arbitrary rule of 70 would suggest renal stone. So it could be increased calcium, decreased phosphate, or increased phosphate, decreased calcium. Because both of them are found in the renal stone. Alright, so we will come to vitamin D. But as you can see right away from here, what is the action of vitamin D here?
Increase calcium.
That's what it does. What will come to it.
Okay.
So, see that fulcrum here?
You see a blind diagram?
No, it isn't horrible.
If phosphate is increasing,
Oh, wait a minute.
calcium is decreasing, and vice versa. So that shows that relationship. And we have just discussed the role of PTH
This word.
on the bone,
Something.
and we have said that it affects osteoclastic activity, increasing osteoclastic activity, and may be inhibiting osteoblastic activity. So we will, as we go on, we will see that calcitonin, on the other hand, has more effect on osteoblastic activity. So PTH has confirmed role on osteoclastic activity. And in this process, both calcium and phosphate are released.
So it makes sense because if you look at it, the thyroid, if you look at the thyroid will be responsible for like bone growth and development. So you can understand why the thyroid hormones will.
Well, the thyroid hormone will have a permissive role. It will have a permissive role more on the growth of tissues, more so than bone. It also may have effect on bone, but it's not as pronounced.
Why I mentioned that is because you were just saying that the osteo, what did you say? Which one?
Well, I said PTH has more effect on osteoclastic activity.
Oh.
PTH. While calcitonin will have more effect on osteoblastic activity.
Okay, sir. And that's what I was saying. You see that because the thyroid gland will also release calcitonin, right? So that's what I was saying that the calcitonin.
Where is calcitonin released from?
It released from the parafollicular
C
cells.
cells, yes.
In the thyroid.
Exactly. Exactly. And that is why I said there are some endocrine glands that are located within other endocrine glands.
Yeah. Wait, so.
Now, the physiology of the control of secretion. This is also important. Remember, when we talked of hormonal control, we are talking of it from the hypothalamus to the anterior pituitary to the endocrine organ. And we also said that there are exceptions to this rule. So, even though that's the general pattern, this is one exception. So, the secretion is not controlled via the hypothalamus or the anterior pituitary, but rather it is regulated by the level of the plasma calcium concentration. Makes sense, doesn't it? Calcium is not a hormone. So you cannot feel bad. Alright, so the secretion is maximum when calcium level falls below 7 milligrams per deciliter. And it diminishes when concentration exceeds 11 milligrams. So it suggests there is a range where the values can fluctuate. If it goes slightly up, the homeostatic mechanism will bring it down. If it goes slightly low, the homeostatic mechanism will bring you up within that normal range. It is when it overshoots this range that you will now have significant increase in PTH. So the release, the secretion of PTH has calcium level as a direct stimulus. So calcium level is a direct stimulus for PTH secretion, whereas phosphate level is an indirect stimulus. So calcium level is a direct stimulus for PTH secretion, whilst phosphate level is an indirect stimulus. If you, what's your name again, Miss?
Me?
Yes.
Rebecca?
Rebecca, if you allow me jump the gun, when we get to vitamin D, you will now see that phosphate level there will be the direct stimulus and calcium an indirect stimulus. Yes.
Sir, the problem that I'm having is that so you're seeing the calcium levels would affect the secretion of PTH, right? But the thing about is that it's not the calcium itself that stimulates the PTH secretion.
So what's the motivation?
Wouldn't it be the I thought it would have been one of the hormones from the pituitary gland.
No, that is what we are saying does not
Yes,
happen.
sir.
So in this case, the pituitary has nothing to do with it. Okay? It is the level of the plasma calcium that is being sensed that will determine how much PTH will be secreted to regulate plasma calcium. Calcitonin can also stimulate PTH secretion. Why? Because the role of calcitonin is to lower blood calcium level. So because of that, it can also stimulate PTH to increase calcium. Yes.
Would that be under negative feedback then with calcium?
Yeah, on a large scale, yes. Because calcitonin, particularly as we will come to see, in patients who are immobilized after a fracture, after surgery, when there is need for bone healing and regeneration, calcitonin plays more role in bone remodeling. And in that process, it tends to increase more of osteoblastic activity. So chances are that it could shift the calcium milieu a little bit lower, that it will now require PTH to boost things up. Magnesium levels also can affect PTH secretion. Increased magnesium level will decrease PTH secretion. So these are some of the physiological bases that I want you to be familiar with and understand the mechanism, such that when you now want to discuss the pathology and the medicine of the parathyroid diseases, be it primary or secondary or tertiary, you will know what is happening and what is the mechanism. Yes.
So when you say the calcitonin stimulates PTH secretion,
Eh?
so the calcitonin, right? You're saying if it stimulates and then lowers blood calcium, that would cause
The action of calcitonin is to lower blood.
Yeah.
Chances are that it would shift it a little bit below the normal range.